We've got Paige Pradko joining us this evening. How are you?
Oh, hi, Bianca. I'm fine. Thank you for inviting me to talk today.
Thank you for talking with us. Now, I wanted to talk to you about OCD. I did come across your YouTube channel and watch quite a few different videos, and I found your videos very clear and concise, and you're providing excellent information. I thought I'd like to talk to you about a few topics, and I thought, OCD was a good place to start. So, firstly, for the listener, if you could just tell us what OCD is.
Sure, absolutely. Before I get right into the description of OCD, which is obsessive compulsive disorder, I would like people just to remember that these are real people. They're lovely, kind, some of the kindest, really most wonderful people I've ever worked with. They are very creative, they're very intelligent, but they have suffered tremendously, probably have suffered more than any other patients that I've worked with. And they're really locked into their compulsions. Some of them actually can do compulsions, which I'll explain in a moment, for hours upon hours, spending 9 or 10 hours in a shower, washing hands for hours and hours, checking uh, door locks and ovens and things like there's many different subtypes of OCD, but they can be locked into their compulsions for hours and really affects the quality of life. Now, if we look at what the actual diagnosis is of obsessive compulsive disorder, it includes someone that has obsessions and compulsions. It also can be just obsessions only, which people call Pure O. But I'm going to talk a little bit about Pure O a little bit later because there really are some compulsions going on with Pure O, but they're just not recognized or identified right away. Um, but these obsessions are like intrusive, unwanted thoughts. People have these thoughts that are actually their worst imaginable thoughts. And they cause a lot of anxiety and discomfort in people. And they try to do something to bring down that anxiety. And what they find is they begin to do different behaviors and they get involved in these rituals or compulsions. And the rituals bring down the anxiety a little bit, but it's just temporary and they get stuck into a cycle. And they also have a lot of avoidance behaviors where they will avoid different triggers, which does affect their life also. Now, it doesn't actually become a disorder unless this is taking up an incredible amount of time in their life, at least an hour or more a day. But most people I work with, it involves several hours a day. And it really gives them, it creates a very difficult life for them. It causes a lot of suffering. And that's when they actually get the diagnosis, when that distress is there.
Mm. Okay. So now you did say that they obsess over the worst thing they can imagine, but I mean, so if they're in the shower for, like you, as an example, you said some
Mhm.
people can be in the shower for several hours. What are they thinking? Are they thinking they're not going to be clean? They're going to get unwell if they don't clean themselves? Is
Yes,
it
there are
always the worst? Is it something just mild that plays on their mind, or is it always as a extreme
it,
thought?
the obsessions, the thought is something that is terrifying to that
Right.
person
Right.
because it really does light up their fear center of their brain. And there are all different
Mm.
themes for the person that I was talking about in the shower. Uh, Her fear was contamination.
Mm.
And she also had a different type of OCD called just right OCD. So when she was in the shower, she was trying to get a feeling that she was clean, but yet she couldn't get that feeling. So in her
Okay.
case, it was a combination of a fear of contamination or germs, along with a trying to get a just right feeling.
Yeah.
But there
Right.
are several different themes in
Mm.
OCD. contamination is one of the most common ones that we see. And the compulsions might be cleaning or washing or avoiding touching things. There are other themes such as people that I mentioned the checking doorknobs and oven. That's a theme that we see a lot.
Okay.
There's also different themes like I'm afraid that I'm going to harm someone, or afraid I'm going to harm myself, or I am afraid I'm in the wrong relationship. That causes people a lot of suffering. I'm afraid that I might actually be a pedophile or harm children. Now, this happens to these are people that would never harm children. This is the opposite of who they are, which is why it's so terrifying for them to have that thought.
So it
Those
sounds
are
like,
just, yeah.
sorry.
Yeah, those are just some examples, but there are several themes, and the themes can change. They can come and go through a person's life. They can get combined where there are several together,
Yeah.
but they're all usually the themes are based on something that actually is the opposite of how that person really is and what they really care about. Um, Someone who has a theme of harming someone is usually a person that would never harm anyone, not a fly. They're the kindest, most wonderful people.
That's interesting, because I think it sounds like it's sort of fear-based too, that they want to get everything so right and, be
Yes.
the best they can be, that fear, then they have that one thought and then they sort of ruminate on it and it grows.
Yes, exactly, exactly. And the rumination can be really part of the compulsion that some people will ruminate and ruminate, trying to figure out, would I ever do that? Could I ever do that? Would I just go crazy and do that? And that's part of the disorder itself.
So when a thought like that comes into someone's mind, I mean, look, I did sort of come across different things like exposure therapy and things like that. And there's another one, acceptance commitment therapy. So
Mhm.
could we perhaps go through a little bit of that to sort of give an example of how, if someone was experiencing OCD, how they could deal with it?
Absolutely. When someone comes into treatment, many times they've been to a few different therapists because OCD takes very specialized training, and there are not too many specialists that work with OCD. But so they've usually been suffering for years by the time that they actually get to see a specialist. And when they come in, the first thing that I do is, with anybody that I'm doing therapy with, is I really try to form a bond with the person I'm in session with. Get to know them, form a therapeutic bond so that they have some trust that develops there in our relationship. And we work together to form a treatment plan. Now, the gold standard treatment for OCD, obsessive compulsive disorder, is called ERP. I'll repeat that, ERP. It's called exposure and response prevention. And what we do is we find out what the person's core fears are, what actually triggers this anxiety or this discomfort, these obsessive thoughts. What are the situations that really trigger that anxiety? And then we do an exposure into those situations. So, for example, if we go back to the person that had a contamination fear, we would actually, she would, get herself feeling contaminated, maybe touch something that made her feel contaminated. Then she would stay in that exposure and not do anything, not washing anything, just stay in that exposure. That's the response prevention, where she is preventing herself from compulsing. And what happens is that the brain learns through that exposure that nothing bad happens. And when you're actually looking at the imaging of the brain, there's new neural pathways that are formed in every exposure.
Really?
And the old neural pathway of the fear, the original fear, is still there. It doesn't go away. But every exposure, we create these new neural pathways. So what we're trying to do is have as many exposures in as many different situations as we possibly can, so that they have a chance in their daily life to have, when they're exposed to their triggers, their fears, so that their brain goes on one of the new neural pathways in the brain where they will not react, and it won't really bother them or raise their anxiety.
So, I mean, I know the brain has that neuroplasticity element to it, but that quickly, that one exposure can change the brain.
Yeah, one exposure can, but we actually like to repeat it and
Yeah,
repeat it and repeat it to
of
really get
course.
that exposure in there good. Yeah.
Yes. So,
And yeah.
sorry. Yep.
Oh, no, no, go ahead.
I was just going to say, so, you know, what happens, what part of the brain is activated with OCD? Is it prefrontal cortex, I think I saw, or is it front or back?
It's actually several different parts of the brain. There is a communication problem within the brain that involves the circuitry from the front in the cortex, going actually through different areas of the brain
Right.
circuitry. We believe that there is this communication problem in the brain of somebody with OCD, as well as some neuroreceptors. Neurotransmitter communication problem. And so when you look at kind of what causes it, although we can't say for certain absolute what causes it, but we know that there is a combination of factors of this brain communication
Mm.
and also genetics. There is a 45 to 65% genetics in the risk factor
Right.
of developing OCD. And also this behavioral component. Some people may have obsessive thoughts and not compulse. And other people will learn these compulsions, and it gets much more serious then. And so really there are a few other different ways you can get OCD also, like children sometimes will get a very severe strep infection, and
Mm.
they can begin the symptoms of OCD. And
Really?
women that are postpartum, about 3 to 6% of women postpartum
Mm.
can develop OCD, usually related to the safety and care of the baby.
So it sounds like that it would be a good thing to get on top of it early, because like you said earlier, people usually seek help when it's sort of set in, and these sort
Yes.
of behaviors reshape the brain. So to get on top of it straight away to sort of then try to reverse it.
Yes, absolutely. The earlier, the better. And
Yeah.
there are some common traits that we see in people with OCD. They they tend to get very sticky thoughts, and even in children, children will be able, you will be able to see in a child that they'll get very sticky thoughts that they just cannot get out of their mind. And they have this inflated sense of responsibility about their thoughts, where they feel very, very responsible.
Mm.
And now humans can have 60,000 or more thoughts a
Mm.
day.
Mm.
And our thoughts can just pop into our head. We can't stop a thought from coming. But people that develop OCD, they they believe that their thoughts are very significant.
Mm.
And when one of these fearful thoughts hits their brain, they just believe this is very
Yeah.
significant, and they have to analyze it and figure it out. Whereas someone without OCD could just let that go. So it's not a real difference in the kind of thoughts that someone has.
Yeah.
When someone has OCD, the difference is how they respond to the
Mm.
thought.
That's right. And can anxiety be a cause of it? Like, when you mentioned young children having it, I'm thinking, well, how would that happen? I mean, I know you said some 45% of it can be genetic, but can something sort of trigger and enhance it in a child, bring it out more, like an anxious situation, being anxious all the time?
That's a really great question. There is absolutely no evidence that that can happen. In fact, a poor childhood, having a very traumatic, terrible childhood, actually cannot bring on OCD.
Yeah, yeah,
Excuse me. There's
yeah.
no evidence of that.
Mm.
And there, if somebody has the predisposition, the genetic predisposition to OCD, and they were in a situation that was very stressful, that might bring out the symptoms,
Mm.
but it cannot cause the symptoms.
Okay.
And this affects, OCD affects 2 to 3% of the population. These are millions of
Is it?
people. That is 1 in 40 people, which means we all know somebody that is suffering from OCD.
Yeah. And I just do want to mention also, because I have seen sort of so many different things on when I was researching this topic, people saying they throw around the concept of OCD it's quite nonchalant, like, oh, I'm OCD. And, people that really have OCD get a little bit upset at that. There's the
That's
Instagrammers hashtag OCD and showing everything neat and tidy. Well, it's not really like that. It's quite torturous, the real OCD.
that's I'm so glad you brought that up. Yeah, we like to get across what OCD really is. And what you're describing is someone that is a little bit quirky, or maybe they like to have their house absolutely immaculate, or they like to have their yard absolutely perfect, or maybe they're very rigid about their finances, or all of these kind of very people that are very high control. That is not obsessive compulsive disorder. Now, they may fall into a category that we call obsessive compulsive personality disorder. That's
Mm.
completely different. And that's a personality disorder. And people that are very, very neat, very precise, and those kind of characteristics, they actually like to be that way. They want to be that way. They're not in distress
Mm.
like OCD
Yeah.
trying to get rid of it. They actually like it. So
Yeah.
it is a big difference. And that's why they're people with OCD want the correct information known.
Yes.
Yeah,
And that was a sort of an interesting thing you just said there, trying to get rid of it, because I think that's what also distinguishes, OCD as a problem, as opposed to someone who isn't sort of suffering from it, because they're trying so hard to get rid of it. They're fighting that one thought that they don't want. It's
that's
that,
right.
because I did see your recent video with, you mentioned Dr. Greenberg,
Yes,
about trying hard and trying to stop the thoughts, and you said something good. You said your only job is to not solve it. So it's that battle, isn't
yes,
it?
that's right. When if you can imagine that, if you just had this horrible thought that I might actually hurt my family members, and that thought felt so real to you,
Mm.
you would want to really try to figure out in your brain, oh my gosh, is that true? Is that
Mm.
false? Would I do that? I mean, it
Yeah.
would be so scary to think that and believe that that was true. And so people become involved in rumination, which is analytical thinking, and they are trying to figure it out, and they're trying to solve it or prove it false.
Yeah.
And what Dr. Greenberg says, he is a clinical psychologist that has Pure O.
Mm.
He says that we can make a choice to not ruminate, that we can't stop the original thought from hitting our brain, but we can make a choice to not get into that secondary fear of analyzing and asking what if and all of that. And he compares it to doing a math problem,
Mm.
that we can do a math problem and then stop doing the math problem, which is analytical thinking. And he said it is the same thing. You can make a choice to stop. And in doing that, it is that is a form of ERP, exposure response prevention, where we are not responding. We're in the exposure, we're having the thought, but we're not responding. And I have another video where I have a technique called I am, and it's very similar to Dr. Greenberg's advice. It is identifying when we have the thought and actually accepting the thought that it's there. We're not trying to push it away or not have it. And then we're using mindfulness technique of connecting to the moment we're living. You know, what do I see around me? What do I hear? What do I feel? And it's some place to kind of take the brain. And then we just move on to what we were doing before we had the thought.
So your concept of mindfulness is sort of making the thought your friend, like not trying to push it away, just saying, okay, I'm here now, I've got this situation, I'm going to sort of embrace it, accept it, and not fight it.
That's correct. And ERP is the standard treatment, but many therapists will combine mindfulness techniques, mindfulness therapy with ERP, exposure response prevention. And they will also combine therapy called ACT, and that's acceptance and commitment therapy. I actually combine elements of both of those therapies when I'm using ERP. Now, acceptance and commitment therapy, ACT, is a very value-based therapy. It helps in motivation. What is this person missing in their life that's because of OCD? Maybe they're missing spending time with family, and that's something they value. And so it gives us motivation to do ERP, which is, even though it sounds easy, it's extremely difficult for people with OCD. And it helps for them to know why they're doing it. They have a value. They're going to do these exposures because they really want to get their life back and spend time with their family.
Yeah, that sounds like a positive thing too. You know, we always hear.
Yeah, and I do want to. Oh, I'm sorry. Go ahead.
After you.
Yeah, I also wanted to mention that that there are medications for OCD, and medications can be helpful for some. They are not helpful for everyone. About 2 out of 3 people they can help with OCD. And the medications that are recommended are SSRIs. They're antidepressants, and they are prescribed in much higher doses than they're prescribed for depression. There are some medications that are not helpful for OCD, and a classification called benzodiazepines are not helpful. And they give benzodiazepines to people sometimes for anxiety. They're anti-anxiety medications, but they can be harmful. And those medications are things like Xanax and Ativan and Klonopin. They are not helpful for OCD, and they actually make exposure therapy ineffective. And so I thought I would just mention that.
Yes, yeah, I'm glad you mentioned that, because what works for one person doesn't work for someone else. So
that's
right.
Correct.
That's right, what you say. Now, just a few things. I just want to cover a few more things before we finish off.
Sure.
Now, I just will mention also, I did like it how you said that, you know, Dr. Greenberg had one sort of point of view and you had your point of view, and you said, oh, he might not agree with that. But I like that, because you're sort of in your videos, you in that particular video, you put sort of 2 different schools of thought, and you said, you know, what works for one person might not work for someone else. But I like it how you sort of give people the option. It's very sort of open to try things, and it can work for someone. So to have that open mind and not be stuck in,
Bianca,
they said that, and if it doesn't work, then I'm doomed. No, because it might work this way.
Yeah, that's such a great point. I'm so glad you brought that up. Even when I'm working with a client with OCD, every case is different. We negotiate every week on what the exposures will be, what we'll do, how we'll do it, how long we'll stay in the exposures, whether everything is constantly shifting. Sometimes we're planning exposures, and sometimes we're doing exposures right in the moment. They're called incidental exposures, right in the moment when
Okay.
it's happening in their life and it's not planned ahead of time. And everything is evolving. Sometimes we're using mindfulness, sometimes we're not. And each of my clients are in charge of how much they want to challenge themselves. What are they willing to do this week? And that's usually what I start with is, we want to know what went well, what didn't go well, and what are they willing to do this week?
Mm.
And this works well. And sometimes I have pushed too hard, and that always backfires on me. So I've learned over the years that really people have to be in charge of what they're willing to do.
Yeah. And
Yeah.
it's right what you say, because what we feel one day, we might not feel the next day or the next week or the next month. We're
Yes.
changing as people. So mindfulness might not work
That's
like the
that's right.
next day, or it might.
That's right. That's right. Yeah. I fully agree with that.
And now, this for me, it was sort of pretty important to raise because watching several different videos, some people said, oh, if someone's got OCD, they're going to have it forever. They're just born with it. They're going to have to learn to live with it, make it their friend. And then I saw another video and someone said, no, the brain can change. We can retrain the brain, and or you might sort of have it a little bit, but you're in control. And then someone else said, look, you can just reshape the brain and, dare I say, get rid of it.
It's really so interesting. With neuroplasticity, we can change the brain at any age, our entire life. I have even worked with an older Indian man. He was 85 years old, and we worked on his OCD, and he made tremendous progress at 85 years old. It's really remarkable that we can change the brain at any age.
Yeah.
And doing exposures changes the brain. Now, I don't use the terminology that OCD is cured, because we can completely, through exposure therapy, have that person not react anymore to their trigger.
Yes.
But let's say they go through a stressful time in their life. They had trauma, or they had major changes happen. An OCD theme may pop up. And what I've found, though, is once people know what to do, they kind of know how to catch it, and they know what
Yes.
to do to not let it get out of control.
That makes sense. It's a bit
Yeah.
like, Alcoholics Anonymous. I spoke to someone recently who sort of was helping out with that group. And, people have said that they'll always have that problem, but they'll just manage it. So for them, they're fine with that. To them, they're cured.
Yes.
They just won't have a drink, and that's fine.
Yes.
So
Yes.
I know it's not exactly the same, but it made me think that as well. Like, we can have something, but manage
Sure.
it and be in control.
That's correct. That's
Yeah.
correct.
Okay. And actually, I just want to go through a few online resources that people can go to, and also how we can contact you and follow you and see your videos and all that sort of thing.
Absolutely. Absolutely. If somebody is interested in mental health topics, especially on anxiety and what to do about anxiety and OCD, they can follow me on YouTube, and they can just look up my name, Paige Pradko, and Paige is Paige, and Pradko is Prad as in David, Ko. And hopefully you will subscribe and enjoy my videos. You can also follow me on Instagram at Paige Pradko Therapy. Now, there are some really wonderful resources online for more information on OCD. One of my favorite resources is the International OCD Foundation, and you can look them up on iodcf.org, iodcf.org, and also peaceofmind.com. Peace of Mind Foundation is dedicated to sharing information on OCD. And both of those organizations offer classes and camps and wonderful seminars. I am always at their seminar. Once a year, they hold quite a big seminar, and I will always be there attending their classes. And we did it virtually this past year. We might do it virtually again this year. I guess we'll see. Yeah, and I did want to give a little bit of information about if someone has OCD or if a loved one has OCD, what should they do? And my suggestion is to try to search out a behavioralist specialist in OCD, a therapist. And how you might do this. Now, a lot of therapists might say that they treat OCD, but they might not have had the specialized training. And so my recommendation is if you could call them and ask them how they treat OCD. And if they answer you with ERP, exposure response prevention, you know that you have a therapist that is trained. If they don't give you that as their answer, I would say thank you very much and hang up.
So that's the best one. That's the one we go for.
Yes. Yes. And it is there are not a lot of these specialists around. It is kind of a subspecialty in therapy, but you can find them, and sometimes you might be doing therapy online. They might be at a different location, but it is worthwhile to go to one that is trained in ERP.
So are you doing sessions online?
Yes. Right now during COVID, all of my sessions are online. And I actually even work as a consultant in all different countries around the world. And it's quite interesting. In many countries, I'm finding there are no resources at all for mental health help. And that is one more reason why I'm so motivated to do these YouTube videos.
And before we finish off, just I understand you're sort of into a few other things as well. You do help people with other topics. Can you just go through a couple of them in case anyone's watching and perhaps can contact you for something else?
Yeah, some of the other areas that I do quite a bit of work in are anxiety disorders, social anxiety, health anxiety, or some people might call it hypochondriac. Health anxiety is kind of a subset of OCD. It's actually a little bit more similar to OCD than it actually is similar to anxiety. And that's also a specialty of mine. I get a lot of referrals from cardiologists helping some of their cardiac patients who are healthy and they're fine, but yet they feel like they're having a heart attack. And that's become a specialty of mine. I also do work with depression because really when you have any of these other conditions, depression usually, kind of comes along with it. So, and other panic disorder, any type of anxiety disorder, those are areas that I do a lot of work with people with those conditions and really enjoy it. It's actually very rewarding work because somebody who has had severe panic disorder and maybe they become agoraphobic and you work with someone like that. In fact, I just had a message online yesterday that someone who had not come out of their house in years was now driving again because of working on their panic disorder with me. And things like that. It's so rewarding to be in this field. And I encourage anyone who is, considering it to definitely look into it because it's a very rewarding field.
Yeah, it would be. And it's interesting too. It's just
interesting,
isn't it? I always say human beings are interesting.
They are.
I've always said that.
Interesting. They are interesting. Yeah.
We're always learning, always learning, right?
We are. It never stops.
Well, Paige, thank you so much for joining us.
You're welcome. I really enjoyed it. And thank you so much for allowing me this opportunity. My passion is really spreading mental health help and information, and you gave me an opportunity to do that.
Well, thank you very much.
Absolutely. Thank you.
Thank you. All the best.
Bye-bye.
Bye-bye.